So cranial nerves, I don't do a lot of testing of cranial nerves, but you should know how to test them if you have to when you're screening a patient, or you start to pick up something when you're talking to a patient, interviewing them, or you might notice something like, looks like a cranial nerve problem. Let me test that. So you need to be able to test these cranial nerves. There's a couple ones we test more than others, specifically, vision, if you're worried about concerns about, safety and are they seeing a certain field of vision and those kind of things. Vestibular system is something we do a lot of specific testing on. Those are the main ones. We do mastoid and spinal accessory nerve when we're testing that. So go through these 12 pairs, pretty much like spinal nerves, but they're in the brainstem and cerebrum. Okay, so they're coming out of the brainstem and cerebrum. So most spinal nerves carry a mixture of everything. They carry motor, sensory, and autonomic. Most spinal nerves carry all three of those as they come out, and most of your peripheral nerves are carrying all three of those. Cranial nerves are a little more specialized, and not all of them carry all those modalities. Some carry just sensory, some carry motor, some carry a mixture, and then there's the special sensory functions. There's vision, vestibular, taste, hearing, those kind of things that are specialized sensory structures. So, boiling it down to the three major functions of the cranial nerves. Motor. From a motor standpoint, they supply the muscles of the face, eyes, tongue, jaw, and two of your neck muscles. Okay? From a sensory, somatosensory, sensory, skin, muscle, joint, that kind of stuff, somatosensory. Information from the face, temporal mandibular joint, and then I shouldn't have put this under somatosensory, so visual, auditory, vestibular, gustatory, olfactory, and visceral, those should be under a category called special sensory, or something special sensory information, not somatosensory. So sorry I put that under that category. So the face in TMJ is really what the somatosensory is for skin, muscle, joint. The rest are special sensations. And then the majority of your parasympathetic control, except for your pelvic organs, bowel and bladder, is regulated by cranial nerves. Okay, regulation of heart rate, blood pressure, breathing, and digestion, mostly by vagus, mostly by cranial nerve number 10. There is some parasympathetic control of your eye for constriction of your pupil specifically, and a little bit of elevation of your eyelid is actually a little parasympathetic part that helps elevate your eyelid that isn't listed there. So there they all are. When you're looking at the inferior surface of a cerebrum and the anterior surface of the brainstem, you kind of start at the top here. There's our olfactory. Then you keep coming down this way, and the next thing you're going to run into is the optic. You keep coming down in the middle here, and you run into the trochlear nerve. Oculomotor nerve. Oculomotor comes out of the space between the cerebral peduncles there. The interpeduncular fossa, that's called. Then when you get to this kind of junction point between the pons and the midbrain, you start moving laterally. You start counting them out laterally. So then you get to trochlear nerve, which is number 4 next. Then you keep moving laterally to the trigeminal nerve, number 5. So then once you then get down past number 5, come back to the middle again and start at the middle. But now we're at this pontomedullary junction. Start counting from the middle, and then again count outwards like this. So this is abducens right here. Then we get to facial at number 7, vestibulocochlear number 8, and then we get to glossopharyngeal number 9. Then we get to the vagus number 10. And now we're kind of coming down the side of the medulla here. Number 11 is spinal accessory nerve, and then you jump one sulci forward to get the number 12, the hypoglossal for the tongue. Okay. So you kind of as you're counting these down, as you're trying, if you're seeing a picture of this and you're trying to figure out which one is which, so you kind of stay in the middle here, you kind of come down this way. Once you get to this junction here, then you kind of start counting out laterally, and then you kind of start at the middle again here, count out laterally and down the side of the medulla, and then jump one sulci forward to get that hypoglossal as you're trying to figure out and count those nerves out. You guys know this. That's what you did the quiz on. I didn't go over the quiz. Hopefully you guys did okay on that. Vestibulocochlear nerve was B, hearing and head movement. Trochlear nerve, which is, it was nice, I gave you both the name and the number. So number 4, trochlear nerve is eyes down and in for the superior oblique muscle. And then optic nerve would be vision, A. Glossopharyngeal, which contributes to taste. Okay, glossopharyngeal contributes to taste. That's C. And then the vagus nerve, regulation of viscera, parasympathetic regulation of viscera, that would be E. Okay. Here's a version of a mnemonic to remember, you know, the nerve itself, the name of the nerve, and then what its function is, whether it's sensory, motor, or both. So some of you may have found other ways to remember those, but that's one option. So we're going to go through 1 through 12, and we may stop and let you guys play and test a little bit on occasion. But we're starting with the olfactory nerve, smell. Sensory, it's a chemoreceptor. Okay, so it's got free nerve endings that act as chemoreceptors. So conducts info from the nasal receptors directly into the medial temporal lobe. This is really the only sense or cranial nerve or sensory experience that goes directly into your brain and limbic lobe without going through the thalamus, without going through another nuclei. It goes straight into your limbic system. So it's considered kind of a very primitive sensory experience. You know, smells can bring up repulsion, you know, feelings and thoughts of joy, and smelling grandma's apple pie and those deep memories that smell. Smell's a powerful, powerful thing and a very primitive thing. We can experience up to 10,000 different discernible scents, but we usually actually recognize these as a taste rather than a smell, and that's what actually gives you flavor. And as you know, when you've got a cold and nothing's really enjoyable and can't taste anything, and so and this, you know, it happens for older adults who sometimes they have failure to thrive and don't want to eat. Part of that is their olfactory sensors get damaged over the years and lose their ability to sense smell, plus their taste buds are getting poor, so it's just not enjoyable to eat anymore. Or if you have somebody who's a long-time smoker or something like that, that can damage their olfactory bulbs, and again, they lose that sense of taste because they've really lost their olfaction. If you want to test it, if somebody's telling you they can't smell something, you close one nostril at a time and you present an odor, usually something like coffee or orange or something like that. You don't want to use ammonia or something like that, because that is like a caustic thing. Even if you don't have a sense of smell, it will cause irritation, and can, if you want to wake somebody up who's passed out, sure, go ahead, but it's not for testing their smell. Don't use ammonia. Use something a little more pleasant. Problem is, a lot of the times somebody doesn't have a good sense of smell. It's because they've got blockages of their nasal pathway. They've got mucus in there. They've got a deviated septum, or they're long-term smoking, which long-term smoking will cause problems with both nostrils. Okay. If you have difficulty smelling, that's the term you use is called anosmia. Okay, so anosmia is the lack of smell. You could have unilateral or bilateral anosmia. Bilateral anosmias are usually due to just smoking or something, or age or something like that. If it's a unilateral anosmia, then you got to decide, is it like a deviated septum, blockage, or if somebody has a history of head trauma, and frontal lobe damage or head trauma, you know, and they have one side, and it's one-sided, like they hit more on the right side of their head and they lack smell on the right nostril, then that could be related to a neurologic problem, okay? Do we do anything about it as a PT? No. Is there anything that anybody can do about it? Probably not. It just may or may not recover. Cranial nerve number 2, the optic nerve. So we'll spend a little more time on the optic nerve because that's critical to what we do and keeping people safe and engaged and be able to see what we do and follow instructions. You're going to get a lot more detail about some of the pathways for the optic nerve when Megan comes next week. So we're not going to get into we're going to gloss over some of the pathways as it goes in. But it's purely sensory for the optic nerve, okay? It relays information from the retina, from the back of your eyeball, to the lateral geniculate nucleus. The lateral geniculate nucleus is a little bump on the back part and lateral part of your thalamus. So it's kind of a part of the thalamus. It's attached to the thalamus. So it does kind of have to go through the thalamus in a sense, but it's called the lateral geniculate nucleus. It sits off the back and lateral part of the thalamus. Some of that information also goes directly into the midbrain, okay, into your midbrain, to brainstem structures without even going to the lateral geniculate nucleus. You have some collaterals that come off that go right into the midbrain, and we'll talk about those. The branches that go to that lateral geniculate nucleus, then they project axons back to the primary visual cortices in your occipital lobe via the optic radiations. The information that goes to that midbrain area, okay, is basically for your pupillary reflexes. So your light reflexes, when your pupil constricts, okay, or dilates according to the amount of light coming in. Just basic awareness of light. Somebody that can have cortical blindness, like they've had a blow to their occipital lobe and their primary vision is knocked out, and they are blind, but if those little collaterals that are going to if the midbrain's okay, they can still sense light and dark. You have some basic sense of light and dark that occurs at the midbrain level. And then also that quick orienting of your eyes to something that's stimulating in your peripheral field of vision that you orient to, that automatic movement of the eye. That's mediated by these signals going into the midbrain, which then the midbrain talks to the superior colliculus, that little area, and then the superior colliculus uses the medial longitudinal fasciculus, those fibers or axons going down to the ocular motor muscles and also to your neck muscles to go boop, and make your head turn towards that. So this is just showing you a simplified thing here. So here's your, I need to have one of you guys be my designated reminder to do that each time, to set the transitions. Of course, now it'll be done. Next year it'll be saved that way. So it'll just be this 1 year. Okay. So here's the back of your retina here. All we're showing is some fibers here of the optic nerve. We're not showing the crossed over fibers, which there are some. We're just showing you the ones that stay on the same side, but that's okay for now. So right here, this is called the optic nerve, this first part coming off the eyeball. Optic chiasm. Some of these fibers cross at the optic chiasm. This picture does not show those crossing fibers. Once you're here, that's the optic tract. Here's the lateral geniculate nucleus back here. Your thalamus is like sitting like this on both sides, and this lateral geniculate nucleus is sitting off the little bit posterior and lateral part of your thalamus. But we're taking the thalamus out of there. And you'll see there's some collaterals that come off here and go right to the midbrain region. Okay, this is just a tegmental region of the midbrain here that it goes to. You know, your red nucleus would be up here, your substantia nigra in here, that kind of stuff. And then from the lateral geniculate nucleus, these fibers go, they have to go around one of your lateral ventricles. Your lateral ventricle coming down and around has to loop around the lateral ventricle. That's why it does. This is called Meyer's loop. Loops around the lateral ventricle, then goes back to the medial surface of your occipital lobes back here. The primary visual cortices are on the medial surface of the occipital lobe on the calcarine sulcus. Remember the calcarine sulcus, which the lingual gyrus is below that, and the cuneus is above that. Those form the top and bottom of, and then that calcarine sulcus there. This right here, this is the optic radiations. These are the optic radiations. Okay. And what happens sometimes in a middle cerebral artery stroke, when you have a middle cerebral artery stroke, sometimes the middle cerebral artery stroke extends far enough to catch some of these fibers from the optic radiation coming to that location there, and can wipe out vision on one half your visual field. So that's how that happens with a middle cerebral artery stroke. And we call that, the term for that is called homonymous hemianopsia. And you'll learn about that on Tuesday. She'll go through the mechanism of that, how that occurs with the visual fields. And I'll probably review that with you a little bit too. It's a little bit kind of not super challenging, but it can be made harder than it needs to be. So to test vision, you can look at pupillary light reactions. Okay, so this is for testing the optic nerve. Okay, so one of the things you can test is pupillary light reactions. The optic nerve, though, is only the afferent part of it. In order for your eyeball to constrict or dilate, light has to get in there to initiate that reflex. So that's how the light gets in. You actually have to use your oculomotor nerve to actually elicit the constriction of the pupil, or you have to use your sympathetic nervous system to dilate the pupil. It has to go down and dilate the pupil. So that's the efferent part of it. You're just assessing the afferent part of it to see if they have a pupillary light reaction. But you have to understand, this doesn't tell you whether the afferent or efferent part is damaged. You have to test both to know whether the afferent or efferent part is causing. If you don't see a pupillary constriction, then you're still not sure. Is it the optic nerve or is it the oculomotor nerve? Okay, and the way you would know if it's oculomotor nerve is because they would also have difficulty moving their eyes in different directions, or you'd see an obvious deficit in where their eyeball is sitting. Plus, with if they're telling you they're blind and they can't see in that eye, and they also can't see when you put light in their eye, then it's probably at least you know it's an afferent part too. I mean, if light's not getting in there and they're aware enough to tell you that they can't see that light, then it's just light's not getting to where it needs to be. It's not getting to the midbrain. So you've damaged the retina, or you've damaged that optic nerve or tract before it branches off to go to the midbrain. Okay. We also have accommodation that's mediated by this. So accommodation is that change in convexity of your lens for focus, so the ability to accommodate in near objects, okay, and to change the shape of the lens to focus that image when it gets closer to you. We also screen visual fields. So visual field screening, where we look at your lateral visual fields, your medial visual fields. And we typically do this where we divide the eyes into quadrants. Okay, so we look at kind of a visual field up here, a visual field down here, another visual field coming in this way from inferior, and then another visual field superior medial. So sometimes I just do a quick screening where you bring in an object, or you say, look at my fingers, which ones are moving, just out in the periphery, just to see if their peripheral vision's okay. But if it's somebody who I know has a deficit that I think could involve visual pathways, then I'm going to get more specific. And we're like, you got to cover one eye while you test all the visual quadrants of one eye. Then you cover the other eye, you test all the visual quadrants of the other eye. Okay? And be specific with that. Acuity, that's how well you can read and see letters, objects, numbers from a designated distance, and those kind of things. That's acuity, what you can look at. So I don't do a lot of that, but you can screen it real quick. That's what these cards are for. So what we're going to do is let you do a real quick little screening process here. So I'm going to show you these cards first of all. I'm just going to pause this while you're doing this. All right, so now we're moving on to, we're going to do these all together. So we'll bang out 3 cranial nerves here at kind of the same time. 3, 4, and 6. Oculomotor, trochlear, and abducens. So here they are. Here's the oculomotor coming right out of that interpeduncular fossa. There's the trochlear right here, the little trochlear. It's a tiny, because it only goes to one muscle. It's a little tiny thing, and it's actually the only cranial nerve that comes off the back side of your brainstem and then goes all the way around to the front side of your brainstem. It's the only cranial nerve coming off the back side of your brainstem. And then the abducens is this guy right here, down the middle, right here at that pontomedullary junction. Okay, so those are the 3 cranial nerves we're going to talk about. What do they do? Primarily, not everything, but primarily control eye movements, the movements of the eyes. Okay. The other thing they do, at least cranial nerve number 3, is it helps in constriction of the pupil. It's the remember the parasympathetic part of that. It has a few parasympathetic fibers in that oculomotor nerve that cause the constriction of your pupil. It's your sympathetic nervous system that dilates it. And that's coming up from your upper thoracic, coming up through those cervical ganglion to go up to your eyeball. This is coming out of cranial nerve number 3, the parasympathetic, to cause the constriction of the eyeball. And this is the efferent part of that pupillary light reflex. This is the action part of it. Kind of like a reflex in your knee. You have an afferent. You got to get the signal to your spinal cord, and you efferent. This is the reflex. This is the pupillary reflex. This is the efferent part of it. The little fibers for this, the parasympathetic fibers, they originate in a little nucleus in the midbrain called the Edinger-Westphal nucleus. Okay, those are those little parasympathetic fibers, and we'll show you this in a second. The other thing they do is there's a few of those parasympathetic fibers that also help to elevate the eyelid. Okay, there's a few fibers at the corner of your eye. Is it Mueller's muscle? I think that little bit is a little extra. There's a few smooth muscle fibers in your eye that help to lift your eye, or your eyelid. And so if you have damage to this, their eye droops a little bit, but it's not closed. It just looks a little droopy, but because you just knocked out a few of those eye elevating eyelids or muscles. So you have 3 nuclei that are located in the brainstem associated with, well, you really have kind of 4, because this has, the cranial nerve number 3 has 2 nuclei associated with it. So for cranial nerve number 3, which is, you have the oculomotor nucleus, and then the Edinger-Westphal nucleus, which is that little few parasympathetic fibers. Then for the cranial nerve number 4, which is the trochlear nerve, it has the trochlear nucleus. Most of the time, the nucleus, the name of the nucleus, the thing inside this, brainstem, matches the name of the nerve. Not always, though. We'll find out later that some like vagus and glossopharyngeal, they share some nuclei that are not even named that, the solitary nucleus in this case, but these guys match up pretty well. Trochlear, cranial nerve, and then the abducens nucleus. Okay, these nuclei are always paired. They're always on both sides of the brainstem because you have left and right nerves, so these are pairs of nuclei. So we talk about control of eye movement, which is that all these 3 nerves work together to do this. You have a superior, medial, lateral, and inferior rectus muscles. You have a superior and inferior oblique muscle. All of the muscles are innervated by cranial nerve number 3, except for, this is how I kind of remember it, SO4-LR6, almost like a chemistry formula. SO4-LR6. SO4 is superior oblique, is 4. LR6 is lateral rectus. Okay, so SO4-LR6 is the 2 that are not inner. So this just shows you how they're lying in there, but I'm going to show you a little cool video that really does a great job of showing you eye movement. This will summarize all the eye muscles and how they function to move the eye. And I hope this sound works on this. That's going to be it.
This finding the actions of the extraocular muscles can be
on my own YouTube channel, because it's like copyright infringement, so I need to go, but that's okay. I just need to remember that when I go back. But you'll have to go out and find it yourself and watch it. You won't be able to see it in the actual video that I've recorded. Does that make sense? So I want to show you where some of these nuclei are located, okay, that are going to these. So here's the oculomotor nucleus right here in red. So the red ones are motor nuclei. And then in green, right behind the oculomotor nucleus, it's a little bit posterior, a little more medial, and we'll show you, I think, a cross-section here at some point, is the parasympathetic part, that Ettinger-Westphal nucleus, okay, the EW nucleus for the oculomotor nerve, okay? And then here is the trochlear nerve right back here, and you see it's coming out the back part of the brainstem. The trochlear nerve is a little interesting because it's the only cranial nerve that actually crosses over as it exits. It actually crosses over as it exits from the back side of the brainstem. And that's right, you see it's right at that kind of junction between the midbrain and the pons is where that trochlear nerve nucleus is lying. The abducens nucleus right here is in the pons, or at this level of the pons. Its fibers drop down to exit out at that pontomedullary junction, to exit that middle part of the pontomedullary junction, just to go to that lateral rectus muscle. Remember, eyes always work together. You know, your eyes never move by themselves. Some people can do some funky stuff, but normally people can't make one eye move separate from another. And if you do see eye movement separate from the other eye that a person's not trying to do, that's not good. That means something's messed up, and that means they're going to be seeing double vision. So anytime you have trouble with your oculomotor nerve, trochlear nerve, the most common symptom is going to be double vision. If you can't get your eyes to perfectly line up with movement, if there's any disruption there, they're going to see two images that are, you know, so they're going to see double vision. Okay? So this is the synergistic action of eye muscles. And the way that the synergistic action, there's a reason why you turn on the lateral rectus muscle on one side and the medial rectus on the other, and they both move the same amount in the exact same proportion, is because they're all linked together. And the way they're linked together is through this little pathway called the medial longitudinal fasciculus. The MLF connects your oculomotor nucleus, your trochlear nucleus, your abducens nucleus, and your vestibular nuclei. You have an ascending component and you have a descending component of this medial longitudinal fasciculus. And the medial longitudinal fasciculus extends all the way down into your upper cervical spine as the tectospinal and medial vestibulospinal tract kind of together. Typically that's what they're called once you get down. Once you look at the descending pathway in the brainstem, you call it the tectospinal and medial vestibulospinal tracts, but some people will still call it the MLF. All the way down into the upper cervical spine, that MLF can extend. And so, and you'll get more information on this next Tuesday from Megan, okay? That's all I want you to appreciate right now, is that they're all connected bilaterally, because you see that these connections are happening bilaterally on both sides of this medial longitudinal fasciculus to allow communication between these nuclei, and so you can get that yoking, that equal yoking of your eyes. No matter which way they're moving, they work together. They're doing that. And then also incorporating any head movement. So the vestibular nuclei are important because you have to have your, like if I want to keep my eyes locked on a target in the back of the room while I move my head, I have to be able to, what we call, this is the gaze, not trying to remember the reflex now, the visual, I'll get it later. But anyway, you got to keep my eyes locked in and be able to, this is the Steadicam thing where I can do this or move my head up and down. So I got to be able to cancel out my tendency to want to move my eyes with my head. So it's a conscious kind of thing, but that requires this coordination between the vestibular nuclei and the oculomotor, trochlear, abducens nucleus, all connected through the MLF to allow that to occur. Or if I want to, I can move my eyes and head all together as a unit, lock them up and move everything as a unit. Or I can move just my eyes without moving my head, but that all requires normal functioning of all those together, being able to connectedly tell each other when not to work, when to work together. But your eyes always are doing the same thing. So either if they're steady, if they're staying in the same place, and I'm moving my head this way, they're not moving together. If I move my eyes and my head together, they're still staying locked in place within my head and moving all together. Or if I decide to look and use saccadic eye movements, voluntary look to different directions, they're going to move together. Okay. So the type of eye movements that we have is, there's a couple different types of eye movements. One is saccadic eye movement, and there's sites of control. So there's different areas of control that influence these different movements. A saccadic eye movement is a movement that can be voluntary or can be somewhat reflexive or a combination, but most of the time it's a voluntary, you're choosing to look to something or an object. And it originates in the frontal lobe of your brain. There's actually a thing called an area that's just in front of your primary motor strip, actually just in front of the premotor and supplementary motor areas. It's a motor area for your eye muscles, to go to your visual muscles and eye muscles to be able to move your eyes voluntarily, okay? Just like the primary motor strip and the premotor. So that's for voluntary motor activity. You have a little region in your frontal lobe for voluntary eye control, looking voluntarily in different directions. And that's a saccadic eye movement. And that's mediated by the frontal lobe. You have a little area on both sides called the dorsolateral frontal eye fields. Then once you've locked onto an object, so once if you're out in the outfield playing baseball or something, the ball gets hit, you hear the crack of the bat, you use a saccadic eye movement to first of all figure out where the object is. So you do a voluntary gaze to try to find the ball. Once you've got the ball, you lock onto it. You know, this is like you're locked on. Once you've got the visual representation of that object in your retinal field and it's gone back to your occipital lobe, now your occipital lobe takes over and can keep your eyes on that object. If you lose it again, like if all of a sudden you lose it in the sun, you got to do another saccade to get to it again, find it again, but once you've got it, your occipital lobe takes over and it just tracks it, keeps tracking the object. That's an occipital lobe function. This is automatic. It's happening in occipital lobe, but it just tracks the object. That's smooth pursuit, or pursuit is what we call that. It's generally, you like it to be smooth. You want your eyes to smoothly follow this. You don't want it to have to jump and keep finding it. If you keep jumping, that means your eyes aren't keeping up with the object. You may have some trouble with your occipital lobe if it has to keep getting these, we call them corrective saccades. If you can't quite keep up with the object, you have to do a corrective saccade to find it again. Most of the time, now if something's moving super fast, so fast that you can't keep up with smooth pursuit, you might have to use corrective saccades, but most things don't move that fast. Vestibular positional, so changes in if I'm swaying back and forth, or I'm moving my head but trying to keep my eyes, or I'm just walking and trying to keep my eyes level without bouncing up and down, I'm keeping them locked on something ahead of me to keep that image stable. That's via the vestibular system, okay? And the cerebellum working together to maintain that position. That's vestibular positional types of challenges to your vision, okay? And then this ability, what's called convergence. So there is a time where our eyes both like this. They move together inwards to try to focus on a near object. That's a midbrain reflex. So when you take and you bring something like a pen right up to somebody's nose and you say, keep your eye, keep it focused, it comes together, that's convergence, that's a midbrain reflex. That's the only time you really activate your two like medial rectus muscles at the same time. Normally your eyes move opposite, right? They always are moving, you know, kind of, especially medial lateral, but this is the only time they really come in together like this is this convergence. That's a midbrain function. We talked about the pupillary and consensual reflexes. So that requires an intact optic and oculomotor nerve to have that reflex intact. If you test somebody and they have normal constriction of the pupil, dilation of the pupil, and it's consensual, then you can make a pretty good idea that they've got intact, you know, optic nerve, at least from a visual light standpoint, and then the oculomotor nerve as well. This is showing you um, some of those reflexes here. So the light's coming in. You've got some of this actually goes back to the lateral genicular nucleus. You'll eventually recognize that consciously, but some of this stuff goes right to this pretectal region right here. And then here is the Edinger-Westphal nucleus, this little nucleus right here. And that will send a signal. Here's that ganglion here, the ciliary ganglion, parasympathetic. It's got actually kind of a long preganglionic fiber, then a short postganglionic fiber to go up and cause constriction of the pupil. But then you see there's also a connection to the opposite one. That's how you get the consensual reactions. So it's got bilateral connections so that when you shine a light in this, you'll get constriction of this pupil, but you'll also get constriction of the opposite pupil. And then if you shine it the other eye, vice versa. Okay, so because you've got those bilateral connections. This is so these little the little parasympathetic ganglia. This is the Edinger-Westphal, not ganglia, nuclei. This is the Edinger-Westphal nucleus. It's right here's the cerebral aqueduct, and then there's this area right here called this periaqueductal gray matter. It sits right there, right next to the periaqueductal gray, just a little anterior and lateral to the cerebral aqueduct is where you'll see that in a cross section. That's the only cross section you'll see of a midbrain. It's right through the middle of the midbrain. It'll always look like that. So here is, and actually, this is the oculomotor nucleus. And I don't know, here they didn't show the oculomotor nucleus, but the oculomotor nucleus is sitting also right next to that periaqueductal gray, but a little more medial and a little more posterior to the Edinger-Westphal nucleus. They show it here. This is the oculomotor nucleus right here. And this is just showing you the connections for accommodation reflex, the reflex that occurs when you have to bring your eye muscles together. So this is showing you this is mediated at the midbrain level via bilateral connections to those medial rectus muscles that when you get that image in your eye, it can converge and cause the accommodation. Accommodation reflex is really both the change in the lens and the convergence at the same time. You know, when you bring in something really close to focus on, you have to get the shape of your lens to change, but you also have to get your eyes to come in together. So that when we say the accommodation reflex is a combination of convergence and change in the lens of the eye. So now we got to talk about lesions of cranial nerve 3, 4, and 6. So these are some of the things you might see. If you have a lesion of cranial nerve number 3, you'll have a lot of problems, right? Because cranial nerve number 3 does a lot of motions, okay? And we're going to show you representations of these lesions. You might see pupillary dilation, right? Because if you've knocked out the oculomotor nerve, you might see since the parasympathetic part is cut out, it's now imbalanced. There's an overdominance of sympathetic innervation because the sympathetic part's coming from lower down in your spinal cord that's not damaged, and so your eye will be dilated. So you might see pupillary dilation. You might see an unresponsiveness to light if you have a damage to your oculomotor nerve. And then we'll take a look at the different things you see when you have knocking out of the cranial nerve number 4 and 6 as well here. This link does not work the best, but what I do have here, let me escape. There's a cool thing, but they're using kind of they haven't updated it very well, so it does this weird thing. This is the UC Davis eye simulator. I'm going to go to right here, eye movement simulator. And so the problem is it only shows that big up in your little corner like that. It used to be nice and centered here, but they just haven't done a good job of updating it with whatever the internet updates, and so it's a little bit primitive that way. But it's pretty cool that way this works. So if you'll notice, when I move my cursor around, you notice that it'll follow my cursor. See that? And then what you can do is you can actually go in and actually individually knock out muscles and then see exactly what it would look like. Now, you rarely just knock out individual muscles. If you usually knock out a nerve, okay, that goes to that muscle. Now, there occasionally, if somebody's got a lot of facial trauma or something like that, they could knock out a individual nerve or individual branch of that nerve. But you usually are going to knock out a cranial nerve number, 3, 4, or 6. And so that's what I really want you to know is what would happen if you knock out a nerve, one of the cranial nerves, as far as what you would see or expect. So we're going to do. They have over here on right eye and left eye, and you have choices here. So we're going to just do right eye in each of these, okay? We're going to do cranial nerve number 3 full, like you knock out the whole cranial nerve number 3, including having the pupillary involvement. If you knock out that whole nerve, you're going to knock out the parasympathetic part of it too, which would affect the pupil. So look at the right eye, and I'm going to knock out the cranial nerve number 3 right here. So let's do this. So now the eyelid would not be that closed. It used to not be that closed. I haven't used this since a little while here. So that's now we're going to take off the pupillary involvement because I wonder if it allows me to open their eyelid at all. Like, no. I want to see what's going on with the eye. So we're going to go here. We're going to do partial. Wait a sec. What? It's what? Oh, what says no pupillary involvement? Let's do partial. Oh, you're right. It says no. Let's do partial. There we go. Okay. So this is what most cranial nerve 3 would look like, although it doesn't show the pupil being. Normally the pupil would be a little bit dilated, open too as well. So if you look at that right eye, you notice that it's kind of sitting in, when I'm asking them to look straight ahead. You notice it's sitting out to the side. Why is it sitting out to the side like that? Lateral rectus primarily is lateral rectus is still on. Lateral rectus is still working, but it's no longer being opposed by medial rectus. Does that make sense? You've knocked out superior and inferior rectus as well, but since you knocked them out equally, it still sits in the middle. It drops down a little bit, but mainly lateral rectus is holding it out there. And this person would be seeing double vision right now. Now their eyelid might be a little further drooped than that, and you'd have to lift up on their eyelid a little bit to really see their eye before you do your testing. So now what I'm going to do is I'm going to ask them to follow. I'm going to pretend that arrow is my finger, and we do this little H pattern. Okay, so if we have the person follow our finger, and you go to one side, and you go up and down like this, and you go to the other side and go up and down, you've got all motions of the eye. So as you go to this one side, the right eye is moving to the outside. This is moving medially. Then you're going up and down to get superior and inferior obliques, doing the up and down here. Although this is more superior rectus and inferior rectus when you're out this way. It's superior and inferior oblique when you're in this way. And then you go over this way and do the same thing. Okay. So now I'm going to have them try to follow. So we're going to go this way. They do a little bit of medial, but they can't get past midline, because the medial rectus just can't keep pulling it over. So they're probably using some superior and inferior oblique to help pull it a little more medial, but they just can't get it all the way over there. Okay. So then we're going to go over here, stay here, and we're going to go up. They don't go up very well on that right eye. It just stays in the middle there. It goes a little bit up. You can get a little bit of superior oblique to get it up a little bit, but it can't go all the way up because you don't have superior rectus. Now we're going to go down. It'll go down a little bit because of inferior oblique. Will pull it down a little bit, but it just doesn't go down as far because of the inferior rectus isn't working very well. Okay. Now we're going to go out to the side, and also then if I go down and in, because I couldn't get far enough medial, the superior oblique can't do its job of getting it down and in very well for the right eye. Normally the superior oblique brings it down and in, with the superior oblique still working, but I can't get it over far enough for the superior oblique to do its job of going down and in. Does that make sense? Or as an effective job of going down and in. If I go out to the side here, it goes out to the side fine because lateral rectus is fine, but it doesn't go up or down as far as you would normally expect. It's more minimized. Now if we go to cranial nerve number 4, so this is superior oblique is out. Let's do this. Oh. And let's get rid of this one. There we go. So right now it looks pretty good. Superior oblique is out right now. Go out to the side here. Good. That looks all nice and normal going up and down this way. Now we're going to go this way across. We're going to go up. That looks pretty good. But now we're going to go down, and you'll notice it doesn't go down and in. That's the main function of superior oblique, is that down and in on that particular eye. Now we're going to knock out lateral rectus. We'll take that one off. I guess you can. Okay, so there we go. So now we're on lateral rectus is out. Do you see how? Actually, I'm going to put this in the middle. I'll put my cursor right in the middle of their nose. So you see that right eye is skewed medial because the lateral rectus is out, so the medial rectus is drawing it over there a little too much. Now, some like kids are saying, have you ever seen kids that have like a little skew deviation, their eye doesn't line up? Some kids have like their lateral rectus muscle is a little too long compared to their medial rectus, so they have to tighten it up, and they go and they shorten that lateral rectus muscle to try to even out their eyes. Your brain can do a reasonable job. If your eyes are only a certain amount out of alignment, your brain can make up for it, but if they get too far out of alignment, they can't make up for it. And so then, so lateral rectus is out, so we're going to go, let's go this way. That looks great. That looks fine. That looks fine. And then going this way, oops, they can't go, they can only go so far laterally, okay, with that. So that's fun to play around with if you get a chance. There's another one out there that's also not quite as easy to play with, but all right. What's it called? What's amblyopia? I think it's mainly has to do with muscle length, that cross-eyed kind of thing, and that's where they're tightening up like the lateral rectus or something like that, or loosening a medial rectus, or a combination of those two. So I think most of the time it's a structural problem, although there could be neurologic problems. I think mostly it's like some kind of a structural muscle length problem. So, yep. All right. We are going to take a break. Any questions? We'll take a break. Here's a picture, or here's a cross section for where the trochlear nerve is. If you remember, the trochlear nerve nucleus is right at that junction between the midbrain and the pons. This is a cross section you'll never see again. You don't have to know this cross section. But so it looks a little funky here. You see this thing in the middle. Don't worry about that. But here's the trochlear nucleus. It's also, here's that periaqueductal gray. It's also right near the periaqueductal gray. So all these, oculomotor nuclei and trochlear and nuclei, they're pretty close to this periaqueductal gray here. But you'll notice that here's the cell bodies. They come out, go around, and then cross over and come out and go out to the front of the brainstem. So it's the only cranial nerves that come out of the back of the brainstem. It's the only ones that actually cross before they come out of the back of the brainstem, or as they come out of the brainstem. Then here's that medial longitudinal fasciculus right here. That's those axons that are connecting the trochlear and abducens and oculomotor nucleus together. Okay. We just did testing of that. Now we're on cranial nerve number 5, trigeminal nerve. Right here, it's huge. It's got a sensory component and a motor component. And it's big. It's got a big sensory component because you got a lot of information coming in from your face. You got a lot of sensory receptors in your face. The motor component is smaller. You can kind of see there's two little divisions to this nerve. There's a little motor part and then the sensory part. The motor is just going to muscles of mastication, temporalis, masseter, pterygoid muscles. So not a lot of innervation there, but it's bringing in lots of information from the face about sensory information. So it's a mixed sensory motor nerve. It innervates the motors of mastication. It also provides, it's interesting, it's got a little bit of sensation up on your eyeball. The outer surface of your eyeball is innervated. The sensory part is coming from it's your sensory from your face, including your eye. It's the afferent limb of the corneal blink reflex. So when somebody touches your eyeball, you want to blink, but you got to feel that touch to blink. The jaw jerk reflex. So you can actually, you kind of have the person like, they kind of have just kind of loosely open their mouth, and you actually take your reflex hammer and you hit down on the tip of their jaw, and you can get a jaw jerk reflex. I've never tested it. I wouldn't want to test it. I would want to be good at doing that. I don't want to hit their tooth or something like that. And I don't know what you're doing with that, other than I think like a facial surgeon or somebody who's trying to test whether muscles are intact would do that, but I'm not going to do that. There's no clinical relevance to us as PTs. When from a sensory standpoint, the trigeminal nerve has three major branches to go to supply the sensory of the face: the ophthalmic, maxillary, and mandibular branches. Okay. So this is where things get a little messier as far as the nuclei that are associated with the trigeminal nerve. Okay. It's actually got 4 separate nuclei associated with that. It's got what's called the mesencephalic nucleus. Does mesencephalon sound familiar to you? Mesencephalon is just another name for the midbrain. So that nucleus is sitting in the midbrain. It's a little tiny nucleus in the midbrain, and all it does is receive the proprioceptive information from the TMJ. So proprioception from the TMJ. Then you have it's called the main sensory nucleus of the trigeminal nerve, the main sensory nucleus. This is where you get all the discriminative touch from the face, conscious proprioception from the face. You touched me right here versus right here versus right here. This is this conscious proprioceptive discriminative touch from the face goes to the main sensory nucleus. Then we have this other big nucleus that's called the spinal trigeminal nucleus. It's where the pain and temperature information goes from the face when it's first integrated at the brainstem level, okay, is the spinal trigeminal nucleus. And they call it the spinal trigeminal nucleus because the end of the tip, this spinal trigeminal nucleus is long. It actually extends all the way from the pons down through the medulla into the first 2 or so cervical segments. If you do a cross-section through C1 or C2, you actually see remnants of this spinal trigeminal nucleus extending all the way into the first few cervical segments. Then we have the motor nucleus. It's just called the motor nucleus of the trigeminal nerve. That goes in the muscles of mastication. Okay, so you've got this broken up series of nuclei that have each subserve their specific function. This is the 3 branches, the areas of skin that are subserved by the different branches of the trigeminal nerve for a sensory standpoint. So when you're doing sensory testing to the face, the key here is that if you, like this is especially if somebody had like a facial trauma, and fractures of their face, and you're wondering if one of these specific branches got injured, you just make sure you test the forehead. So the 3 areas you're going to touch: forehead, cheekbone, and mandible. Okay, so ophthalmic, maxillary, mandibular division. So just boom, boom. Just kind of like when we're doing sensation of the limbs, we always want to make sure we hit the thumb, middle finger, small finger, and the leg. We have certain dermatonal or skin regions that are important, distal to well, this is just forehead, cheek, mandible, chin, to get those particular. It's like a mask. Think of it as like a mask. You see, then you start getting cervical stuff to the back of the head, neck, and shoulder region, upper neck or lower neck. So here is from your book showing you the functions, the motor functions on top and the sensory functions on the bottom, and all the nuclei associated with them. So you can see that the trigeminal nerve has nuclei in every part of the brainstem. It's got parts in the midbrain, parts in the pons, parts in the medulla, and even parts in the spinal cord. So it's just massive. There's just a ton of sensory information, especially sensory, coming in. Okay. So let's just start motor first. So here's our muscles of mastication. And there's this little motor nucleus sitting right here in the pons. And then it goes out to those muscles. Okay? Motor nucleus of cranial nerve number 5. You have one on each side. All these are paired nuclei. Now let's talk about the sensory structures. Okay? So here's the mesencephalic nucleus. The mesencephalic nucleus is up here in the midbrain. Little tiny nucleus up in the midbrain. All that is bringing in, it's that proprioception from the temporomandibular joint. Goes to that mesencephalic nucleus. Here's the main sensory nucleus. This is clearly just in the pons, the main sensory nucleus. And it's receiving information about discriminative touch from the face. All three of the divisions of the ophthalmic, maxillary, mandibular divisions, the touch, discriminative touch. And then here's this massive, long pain and temperature not sensing, but that's where pain and temperature goes first, is right here into the spinal nucleus of cranial nerve number 5. And what it does, it's interesting how this does this, but this information comes in, and it actually goes down and makes connections as it descends. So there's a pathway that goes down like this. It's actually called the trigeminal lemniscus, this little pathway. And as it's going down, collaterals come off and make synapses with that long trigeminal, spinal trigeminal nucleus. Okay, the spinal nucleus of trigeminal nerve. That information that's going to this mesencephalic nucleus, to this motor, or not the motor, to the main sensory nucleus, to the spinal nucleus. Once it makes its connection, if it's going to go to where you have conscious awareness of it, it's actually all going to cross over. It's going to go up to the thalamus and then go up to your cortex, okay, for the area of your face and so it makes that connection, comes in on one side, but then it all crosses over to go up to the opposite side. So this is a contralateral. These sensory pathways are contralateral, okay? Contralateral sensory pathways. When you have lesions of the cranial nerve number 5, you can get a number of things. You can get, if you just damage the nerve to irritate it enough, like you get some compression and you screw up some of the myelin on it, or it gets inflamed or infected, you can have what's called a trigeminal neuralgia, where it just sends these massive pain signals, okay? Because you noticed how much, a big percentage of the trigeminal nerve is going towards pain and temperature reception. And you see how big that nucleus is associated with it. And so anytime you mess up the fibers a little bit, you can get this trigeminal neuralgia that can lead to this massive stabbing, shooting, pain, supposedly some of the worst pain you can feel, where people literally say they think about committing suicide because the pain can be that severe. Facial pain, and this has to do also with like headaches can be, this trigeminal complex is associated also with severe headaches and so forth. So people that have this problem are really in severe pain. Most of the time it goes away on its own, but and the problem with this trigeminal nerve pain, opioids don't touch it. It's very refractory to opioids or anything like that. So they often use things that are like anticonvulsants and epileptic drugs because it's a neurologic dysfunction, misfiring of nerves that are nearby each other that causes this. So you're having to quiet it down. They're trying to quiet the nerve activity, not dampen it through opioid receptors and so forth. So, and people with this is common in MS. The transition between a cranial nerve and your central nervous system, there's a little bit of oligodendrocytes that kind of like in that transition. So people can get MS can have a trigeminal neuralgia. They also get optic neuritis because the initial parts of your optic nerve and your trigeminal nerve, it's not all Schwann cells right there. There's some oligodendrocytes, so they can actually get some lesions in that transitionary area that cause like these optic neuritises or trigeminal neuralgias and so forth. But a lot of times the trigeminal neuralgia, they don't even know what causes it. It's idiopathic. Just they get an inflammation in that that sheath and the myelin and around the trigeminal nerve. Okay. If you get a specific lesion to certain branches, like if you get just the ophthalmic branch of the nerve going to the ophthalmic area, then you could get loss of the blink reflex because that goes to that outer part of your eye, and then also sensation just in that region of the forehead area. Okay. Versus if it's more just to the maxillary or mandibular division, then if you lose the mandibular division, you'll lose the afferent part of the stretch reflex for the jaw reflex, or they also loss of sensation in that jaw region. We're not going to really go through testing here, but all you do, and you can do it to yourself, to test like the motor part of it, you basically have the person clamp down. Okay, and just like grit your teeth together and palpate your temporalis muscles out here on the side. See if they're contracting and see if they feel the same on both sides. The bulk is the same on both sides. Then you can also do it down here in the masseters and pterygoids. Just kind of see if that bulks out the same. Now there are little appliances you can actually put in somebody's mouth and measure their force that they can create and measure side to side. Put it on, if you want to like really get into some in-depth. We don't do that as PTs. I just do a quick screen, just clench your teeth. You may do this, especially if you're working in a TMJ clinic or something like that, where somebody's got dysfunction. They get atrophy and weakness over time because they're not chewing with one side of their face or something like that. You can get some of it an appreciation. If you're working in a TMJ clinic, you may have some of those bite sensors that you can actually measure that force. The other thing then would be sensation. And what you're going to do is you're going to do forehead, cheek, and the mandible with light touch, sharp, dull. With light touch, you have them close their eyes while you do that, and you can say, where am I touching you? Forehead, cheek, and that'll give you the discriminative part of that, and then you do sharp, dull. Okay, a couple points in each of those areas. And then if you are worried about their ability to sense, if they don't feel their forehead and you're worried about them not feeling their eye, because that you want to have a decent blink reflex, you can take your little cotton swab and you twist the end of the cotton swab and kind of make it a little bit wispy at the end, and then you open their eye and you poke that little wispy end of the cotton swab just to their side of their eye. You could have them look to one. You could have them look to one side, and you touch it here, and then you see if they blink. So, test that. Yep. Cranial nerve number 7, facial nerve. Again, facial nerve, not as critical to us as PTs, but we should be able to know what's happening with it and be able to test it. So we're down here. We're at that pontomedullary junction. And actually, no, I just circled the wrong ones. I circled abducens. It's the one right here. So the next one out. So on each side. It is a mixed nerve. Okay, so it has multiple functions. It has a sensory, a motor, and parasympathetic division. Okay. From a sensory standpoint, you get touch, pain, and pressure from the tongue and the pharynx. Tongue and the back part of your throat there a little bit, the pharynx. And then also it has your taste for the anterior part of your tongue. The anterior 2/3 of your tongue is the taste reception. So that's a special gustatory sense, so it's special sensory information. The touch, pain, and pressure of the tongue and pharynx are considered a somatosensory, type of sensation. From a motor standpoint, it does eye closure, it moves your lips, your facial expressions. It's the efferent limb of your corneal reflex. So the trigeminal nerve is giving the sensation on your eyeball, but when you touch it and you blink, that's your facial nerve doing that. It's the efferent part of that. Then it has a few parasympathetic fibers. It has parasympathetic fibers that innervate salivary, nasal, and lacrimal or tear glands, okay, for secretion. Because it has, at least in this case, it has 3, and it happens to match up that it has 3 nuclei that are associated and help subserve those functions. So the cranial nerve number 7 has the facial nucleus, which is the motor part, okay? Then it has the salvatory nucleus. It's nice that it's called the salvatory because it has to do with the salivary, nasal, and lacrimal glands. So it helps kind of remember this is what it's associated with. So this is that nucleus, parasympathetic nucleus, that is sending signals to those glands to secrete fluids, saliva, tears, those kind of things. And then we have the solitary nucleus. The solitary nucleus is a nucleus that a lot of cranial nerves use. It's an afferent structure. You're going to see this solitary nucleus show up in at least 2 other cranial nerves, okay? And the cranial nerve number 7 uses a solitary nucleus. This is where taste goes to in the brainstem initially, is to the solitary nucleus. So here is the picture, so showing, here's the facial nerve nucleus right here. The facial nerve nucleus is in the pons, but it also, its axons drop down and then come out of that pontomedullary junction. Here's the salvatory nucleus. This is actually, it's in the medulla, right there, salvatory. That's parasympathetic fibers going to lacrimal, nasal, and salivary glands. And then down below that, also in the medulla, is the solitary nucleus. The solitary nucleus is pretty decent size, and we'll see it in cross sections. The salvatory nucleus, some of these nuclei are so small you just don't see them in cross sections with the naked eye. But the solitary nucleus is pretty big because it receives afferent information from a few different nuclei. So the solitary nucleus, when we get into cross sections, we'll show you where that's at. But it is going, this is where taste to the anterior 2/3 of the tongue. So when we talk about cranial nerves, including the cranial nerve number 7, if you damage the nucleus of a nerve or its peripheral nerve as it's exiting that side, it's going to cause ipsilateral loss of function, okay? So this is true of the cranial nerve number 7. So if that number 7 cranial nerve, if I damage the nerve itself, if I damage that whole nerve, I'm going to have loss of all those functions on the same side as the lesion. So if I damage my right facial nerve, I'm going to have loss of function in my the facial structures on the right, loss of some sensation, loss of taste on the right side of my tongue. If I damage the nerve or the actual nucleus in the brainstem, okay? If I damage the nucleus or the nerve, the lesions on one side, the loss of functions on the other side, okay? If you damage above the lesion or above the nucleus, called supranuclear. So anytime you damage something above the lesion, or above the nucleus, it's called a supranuclear lesion. This is true of other cranial nerves, not just cranial nerve number 7. So if I want to smile voluntarily like this, just smile, I send a signal from my brain, from that facial area on my motor cortex to tell my facial nerve and facial nucleus to do that motor action, right? It crosses over to go to that side. If I have a lesion, supranuclear lesion, up in the cerebrum, corona radiata, internal capsule, even the front part of the midbrain before you get down to that, anywhere above the cranial nerve nucleus, that's called a supranuclear lesion, then the lesion would be on the opposite side of the dysfunction, okay? So I ask somebody to smile. They only smile on this side. I know by an MRI that their lesion is in their cerebrum. That cerebral lesion is contralateral to the loss of function. The same with our body. These are cross tracks, both sensory and motor. If they're making it up to conscious awareness or you have voluntary control over it, they're all cross tracks, just like they are to my limbs, okay? And the same thing with our spinal cord or anything. If you damage a peripheral nerve going to my arm, on the right side, it's going to cause right arm weakness. Or if I damage the anterior horn cells actually in the anterior horn going to those muscles, that's going to cause weakness on the same side. But if I damage up here in the cortex, that's going to opposite side, so it's contralateral to the lesion. The only thing that's unique about the facial nerve nuclei is the upper part of the facial nerve nucleus, which supplies the upper part, your eye, just above your eyebrows and up. It gets bilateral innervation. And so if I have damage to my left side of my brain and I ask somebody to smile or do things with their face to test the facial nerve, the motor part of it, they they'll be able to move the lower, they won't be able to move the lower part of their face very well, but if I ask them to raise their eyebrows up, they move pretty symmetrical because the other side of their brain, the left side of their brain, there's bilateral connections going to the upper part of the facial nerve nucleus. So all I'm saying is if the lesion is supranuclear or up in the brain on one side, the lower face will be disproportionately weak on one side compared to, you won't see that upper face being as big of a difference. You might see a little sluggishness, but the upper face, the eyebrows, the forehead have bilateral innervation. So it's very unlikely that you get loss of upper face movement when it's supranuclear. If you wipe out the whole nucleus, you'll have the whole side of the face, including the upper part of the face, will be weak too, if you wipe out that whole nucleus. But if you're wiping out somewhere on just one side, the other side supplying both nuclei, the top part of the nuclei, so you get less pronounced deficits in the upper part of the face if it's supranuclear. Does that, you guys kind of clear on that? Have you guys heard of Bell's palsy? That's like a trigeminal. This is a facial neuralgia, facial nerve neuralgia. So this is where you have acute unilateral inflammation of a facial nerve, which causes their whole side of their face to be weak. And recovery, most people do recover from it. It's self-limiting for most people, kind of like trigeminal neuralgia is self-limiting. It could be even a virus or something like that that causes this. It could be after somebody has a sickness or illness, almost like what you'd have with a shingles or something like that. But this is just an irritation of the nerve, and they get weakness. However, if it damages enough of the axons, if it doesn't just attack the myelin and some of the axons get damaged, they don't get full recovery. The older you are, the less chance of full recovery. So if you get this in your 60s or 70s and you get Bell's palsy, you get it mostly back. But I watch, like when I'm watching interviews of people on TV or something, and I'll notice that they have an asymmetric face or smile, and a lot of times it's just they had Bell's palsy once in their life and never fully recovered. And so not everybody recovers. 80 to 85% recover from the Bell's palsy, and there's nothing you can do to really speed it up or make sure it's a complete recovery. They used to give out these little stimulators that you would try to stimulate your face to maintain the function in your muscles. And because you wiped out a peripheral nerve, you'd have to use direct current because alternating current doesn't work with it. And you got to use the nerve to actually, if the nerve is wiped out, you can't really do stimulation, and you use this direct stimulator, and it's actually quite painful. And because you put it on your face, which is full of all these pains receptors, and then you click on this little button, and it goes, and it makes your muscle contract using direct current, but you still have good sensation a lot of times, and so it's painful because you have trigeminal nerves, okay, so your facial nerve is what's damaged. And then also what it does is the stimulus is so strong, it actually depolarizes your optic nerve too, so you see this flash of light every time you do it. And you got to do it hundreds of times, a couple times a day. They used to do this, and it was crazy, but and people thought it would help, but now they did some research, and actually they found out if anything it actually makes things worse. It doesn't help at all. If anything, it might make things a little worse doing this stimulation to your face, so you just got to wait it out basically. So number 8, cranial nerve. And we're going to just kind of really go past this one because this is what you're going to get talked at or about on Tuesday, vestibular cochlear nerve. We're going to do, I think, just talk about the cochlear part of this mostly. She's going to talk about the vestibular branch. This has 2 branches. A vestibular branch, which tells you about head position and angular movement, speed of angular movement of your head. So position of your head in any given moment, relationship to gravity, then any angular movement of your head will be registered by the vestibular branch. Cochlear branch is hearing, okay, auditory information. You have these peripheral receptors that are located in what's called the labyrinth, which is your semicircular canals and your cochlea together, this labyrinth. They both use similar types of receptors, these hair cells that deform, according to sound waves vibrating them or fluid in your inner ears deflecting them in one way or another. And that's how you register these signals. That's how you get, these are mechanoreceptors. They depolarize in response to a mechanical stimulation of some type. So you have 2 nuclei associated with the cranial nerve, which is, this all makes sense. You have a vestibular portion, or vestibular nuclei, for registering head movement and helping with equilibrium. So those are, remember we have the 4 superior, inferior, medial, and lateral vestibular nuclei right at that pontomedullary junction, right where that cerebellum is. And then we have the cochlear nuclei, which is for registering information about hearing coming in first, goes to the cochlear nucleus in your brainstem before it goes up to your brain. Or it goes to other places in your brainstem as well. We'll show you with that. So let's talk about just the auditory system today. Some general functions. So the auditory system does orient head and eyes towards sound. So anytime you hear a loud sound or a threatening potential sound, your eyes and head will tend to, you guys know this when somebody walks into a room or any kind of noise is made, it's like you have to really think about not moving your head for it to, just everybody wants to turn and look for that sound. That's just built in, sort of hardwired into us. Sound will also cause general activity, increased activity level in the central nervous system. It can cause decrease, though, too, if it's very rhythmic in nature and soft sound. So it really depends on the nature of the sound, how it affects. So it doesn't just increase. You can get it to with habituation. And so soft lullabies and sounds and monotone voices like mine that make you fall asleep while you're listening to my lecture provides some awareness of or does influence the overall activity. You have these, when you first get sound coming into your cochlear nuclei, you have direct connections with the brainstem centers. There's a thing called the reticular activating system. There's some cells in the middle part of your brainstem that project up to your cerebrum to release norepinephrine to make you awake or alert, or can downregulate to stop secreting norepinephrine based on the sound that's coming into them. So we can use that to our benefit. If you have a patient who we want to get woken up, we might use an upbeat voice. We might actually create a little bit of noise or bring in some upbeat music that they're used to and that they've experienced before to try to wake them up for a therapy session. Or vice versa, if I have a patient who's an agitated head injury patient, we might put on some soft music, and we might dim the lights too, and light some candles, and have a nice dinner. Whatever works, to get them to calm down. Provides conscious awareness and recognition of sounds. That's what we think about mostly, is like, hey, hearing is so I can hear things and like, oh, that is a bird, or that is somebody talking to me, and this is what they're saying to me. That's what we also do. So just kind of thinking about, we have outer, middle, and inner ear. So outer ear is the ear canal itself and your earlobes, the pinna, an auditory canal. That's your outer ear. Then we have the middle ear, which is your ossicles, okay? So your different small bones associated with the middle ear, okay? And then the inner ear, this is the labyrinth. So inner ear is that labyrinth. And we're just going to be talking about this part of it, just the cochlea, okay? That snail-looking thing is the cochlea, is what we're going to be talking about. You'll hear about the semicircular canals on Tuesday. So we have receptors and nuclei. So we have these mechanoreceptors that pick up sound. So we're just talking sound today. And that's via the organ of Corti, which is in the cochlea. Then once the organ of Corti is stimulated, signals are transmitted on the cochlear nerve, okay? Vestibulocochlear nerve. It's 2 parts. So you actually do have a vestibular and a cochlear part that are all part of cranial nerve number 8. But they are distinctly 2 different divisions of that cranial nerve number 8. Then you goes to the cochlear nuclei, which are in the pontomedullary junction region. There's so many things in the pontomedullary junction, between that pons and the medulla. And we get through some cross sections in there, you're going to see a bunch of cranial nerves popping up. And there's a scary cross section through the pontomedullary junction that has a lot of the cranial nerves that you'll see in there. So let's see here. So here's a cross section through, here's the cochlea. We're taking a cross section through the cochlea, and you see it has these different chambers, okay? So it's got these 3 different kind of chambers as you take a cross section through this, kind of like a cinnamon roll. And when you open up the cinnamon roll and you cut the cinnamon roll, so I want a cinnamon roll now, and it's got these little holes or chambers in it. It's got what's called the scala vestibuli right here, this top one, a scala tympani, which is this lower region, and the scala, the scala media. It's kind of in the middle, scala media, so that makes sense, okay? This is your organ of Corti, this little area here, which is that complex of cells that have the mechanoreceptors, these little hair cells that project up into this little stiff, little almost like cartilage called the tectorial membrane. Okay. And so when we get deflection of vibration of sound, making there's fluid in here, this fluid vibrates and it causes vibration of these chambers, and that causes this tectorial membrane to kind of start flexing up and down on top of these hair cells that are projected into the tectorial membrane, and as it moves up and down, it deflects them and causes mechanoreceptors, mechanical gated sodium channels to open and cause depolarization to encode the signals and as action potentials are going to go to those cochlear nuclei. So this is a little bit more of a kind of honing in on that. Here's this whole thing is our organ of Corti. Here's the cell bodies. Here's the little stereocilia, which are the little hair cell membranes. The stereocilia project up in there. And so when we get deflection of this basement membrane, or here's the basement membrane here. So really it's this basement membrane deflecting on this relatively stiff. You get some movement of the tectorial membrane as well. It's a combination of movement of the tectorial membrane and the basement membrane. As they move and deflect, you just get tweaking of the hair cells, one direction or the other, okay? And that causes action potentials to occur, depolarization. So here is kind of here's taking the cinnamon roll and rolling it out basically into a straight line here. And now what we have is we have the top part of this chamber up top is the scala vestibuli, and then the bottom chamber here is the scala tympani, okay? And so here's our stapes, part of our middle ear, part of our ossicles. It gets vibrated. This is the oval window. It's attached to this oval window, and it's vibrating back and forth. That sets up a wave of vibration that goes through this scala vestibuli. That wave of vibration, of movement of fluid goes through the scala vestibuli. That is transmitted all the way down through, there's a little hole at the tip here called the heliocatrema, or heliocatrema. That fluid can move, and that vibration through the fluid can move through that heliocatrema, then back down into the scala tympani. And then you have what's called the round window, which is a little nice thin membrane that can bulge in and out with the vibrating. That allows the fluid to actually, if it's too closed, the system, the fluid can't vibrate. You got to have a little bit of a area that allows that to bulge out so that the vibration can transmit through that fluid, and that's what the round window does. It bulges in and out as the fluid inside of there is moving, okay, to allow that to occur. This is the basement membrane, this thing right here. It's all the way through the middle of that structure, and the basement membrane changes in thickness from one side to the other. And so every object or membrane has a certain resonance frequency that it tends to want to vibrate at. And so depending on the frequency of the vibration of the fluid, it will tend to cause one part of this basement membrane to deflect more than another. So if you have a higher frequency vibration, the part of the membrane that tends to want to deflect with higher frequencies will deflect because it's thinner or thicker, and that matches up with what's called its resonance frequency. I think I've got a picture here. So you see here is high frequency tends to deflect this more proximal part of the basement membrane, and lower frequencies where it deflects this more distal part. So you can see here's that stapes. It's moving the fluid. Here's the round window. This is going through the heliocatrema, but because this has a certain frequency to it, it will only deflect the region, or tend to maximally deflect the region that has a similar resonance frequency, that has the thickness that matches up and is going to be deflected most easily by that. And that's how you encode sound by depending on at any given moment which part of that basement membrane is deflecting and stimulating the stereocilia in that part of the organ, the chordae, that will send that signal via a nerve. You know, this is attached. The organ of chordae is in here too, but it sends that nerve signal from that region to say this is the current frequency of sound being sent, and goes to your cochlear nucleus, then up to your temporal lobe to make sense of it, okay? So these are actually all the connections you have for auditory connections. So everything starts at the organ of chordae, right, which is receiving this stimulus of different frequencies because you're stimulating and vibrating different parts of that basement membrane. That signal is sent first to the cochlear nuclei, which is in your brainstem. The cochlear nuclei then sends signals to different regions. Some of that goes to the reticular formation, which is just that area within your brainstem, and that part of the reticular formation called the reticular activating system, which is for just kind of activating or depressing your entire nervous system. That's those things that project up, secrete norepinephrine into your cerebrum, and that can adjust arousal, just overall arousal level, up or down, that connection of the cochlear nuclei to the reticular formation. Part of this message goes to the inferior colliculus. Remember the inferior colliculus? There's a superior colliculus for visual information, for when you see visual stuff and you want to look towards it. Well, there's the inferior colliculus, where there's a little relay center there, a little nuclei on both sides, that some of that information goes there and tells you your head to turn towards a sound. Okay, so your head wants to move towards both visual stimuli and sound stimuli. And that starts at the inferior colliculus, but then goes up to the superior colliculus so that your eyes will turn towards that. But then also some of that goes down, some of that goes from the inferior colliculus down to some of your vestibular tracts, medial vestibular and lateral vestibular spinal tracts, to make your head turn as well. But that's not in there. But for conscious awareness of sound, the stuff that's going to go up to your brain and your cortex, it goes to first, from the cochlear nucleus, it goes to what's called the medial geniculate body. So remember, vision went to the lateral geniculate body. That's another little bump on the side of the thalamus. Well, auditory information goes to the medial geniculate body. Then from the medial geniculate body, it projects to the primary auditory cortex, which is in your temporal lobe. Okay, just on the top part of the temporal lobe, we'll show you in a second. And that's where you get the conscious awareness of hearing. But then from there, it actually goes up into your parietal lobe to actually make sense of it. What does that mean? So this is showing you some of those connections. Don't worry about that, superior olive. Just know that when you send information in from the ears, you actually have some bilateral connections. So you send information to both sides of your brainstem. So over here you have the same thing happening. You send information to both sides. So if you actually have damage to central pathways for hearing on one side, it tends not to cause complete deafness, because you have information coming from the other side that goes to both of those. It might cause you a little bit of difficulty with localizing sounds, but it doesn't cause complete deafness. The only time you have complete deafness is if you wipe out the cochlea itself fully, or the whole nerve out here. Anytime you impact any of the central connections, it doesn't lead to complete deafness, because you're getting information from both. As long as it can get into those central connections, it gets distributed to both sides. So if you only wipe out one side centrally, that's getting information from the other side, so you don't perceive it as deafness. You might have trouble a little bit, like, where did that sound come from? I have a little hard time localizing it. So only when you wipe out the peripheral nerve or the peripheral middle ear, and the nerve itself, cochlear nerve, that's when you can have true deafness. But this is just showing you, all you want to appreciate here is projections up to the inferior colliculus. Here's the medial geniculate nucleus body that goes up to this region right here on the superior part of the temporal lobe, and I'll show you this in a second here. So it goes to the primary auditory cortex first for conscious awareness. That really gives you an awareness of more of the intensity of the sound. Doesn't give you a lot of awareness of the meaning of the sound. You have to go to the auditory association cortices before you say, that's a bell, that's a whistle, that's a person talking to me. Initially it goes, the primary is just for interpreting primarily the intensity of the sound. If you recognize it as a language, there's a part in your brain called the Wernicke's area then that interprets language. And it happens to be for most people just on the left side of your brain. On that left side of it's in the parietal lobe. That's for interpreting language, okay? The right's for spoken language. The right side of your brain in that same Wernicke's area is for interpreting nonverbal language, which 80 to 90% of our communication is nonverbal. So it's just as important, if not more important, than verbal comprehension. So here is this little purple part. That's the primary auditory cortex. This is that lateral fissure, Sylvian fissure, lateral sulcus here. It comes right to that top edge of the temporal lobe. This whole thing is the superior temporal gyrus right here. So it's in that superior temporal gyrus. Then this little yellow area right here is the secondary auditory cortex. So this is where you encode the frequency and the intensity. So it's layered in here in different frequencies, go to different parts of your brain of that primary auditory cortex, and the intensity, how loud the sound is. The secondary area, this is where you classify it. This is where you say, oh, that's a bell, that's a whistle, that's somebody talking to me. If it's somebody talking to me and I need to interact with it, I need to understand it, now I send a signal from here. This is the left hemisphere. You're going to send a signal up to this, there's a region right up in here. This is that parietal lobe, right? This is an association area. This is the Wernicke's area right up in here. That makes sense of that language and gives it meaning. Does that make sense, sort of? Now, talking about disorders of the auditory system or disruption, there's different things you can have. One is conductive deafness. This is where you have some difficulty transmitting the vibratory impulse to that inner ear and getting that stimulus to the cochlea. You can't get the vibration there. So this is where you have wax in your ear. You're blocking the vibration of the air getting in there. Otitis media, so some type of a ear infection or inflammation, okay, in your ear, that the outer or middle ear is affected here and reduces the ability to transmit the vibration to the cochlea. We also have what's called sensorineural deafness. Okay? If you have sensorineural deafness, you have damage to the receptor cells or the cochlear nerve. So this is where you're damaging the actual receptor cell or the nerve. This is where you can have, this would be like, both of these can cause deafness. One's due to the conduction of the air and the vibration. One's due to actually damage to the nerve or the receptor. Okay, so none of this is so nothing's ever making it. Barely. Well, it can make it into the cochlea here, but the nerve, it's not making it into the brainstem. So you're blocking transmission of information from getting into the brainstem and cochlear nuclei with both of these. And it can be varied depending how much wax you have in your ear, how bad the damage is. It can be complete deafness or it can be partial deafness of some type. Okay. As I mentioned before, if the lesion is in the CNS, it rarely causes deafness due to all the bilateral connections, but sound location can be impaired. Let's do this. Let's take a quick break. I'm going to grab tuning forks, and then we'll play with some tuning forks for doing a little bit of testing of some of these different types of deafness, and show you how you would do a quick screen in the clinic. All right. Let's talk about screening hearing as a physical therapist, you know. And actually now with like phones, I'm sure there's apps and stuff you can actually do some screening of hearing a little more accurately. You know, you put whatever earbuds in their ear, and there's probably some app you can test this. So, but if you want to do a quick, crude screening of hearing, and also then try to determine what the cause is, whether it's a conductive type of deafness or sensory neural problem. So first of all, if you just want to screen their hearing, first of all, you need a quiet room. That's the hard part, is finding a quiet room in the clinic. You can take your fingers and rub them together and just start bringing it slowly towards their ear and tell them when they can first hear your fingers rubbing together. You just got to be good at doing, you know, as long as you're doing it the same each time, you do it to both ears and you just see how far away, you know, that they can hear that, and that's how you can kind of screen, is one side worse than another. Most of the time they can tell you, but you can see just how bad is it, you know. They used to say you can use a watch, you know. I'm like, no, we don't have ticking watches. I'm sure you can find an app that simulates a ticking watch, and you can bring it up to their, you know. So that's just a quick screen of just how bad is their hearing, you know. But now you want to know, like, does this person have wax in their ears, or do they have, you know, do they have a cochlear, inflammation or a cochlear nerve problem? So we want to know if it's that conductive deafness versus sensory neural deafness. So here's a way you can do this, and you typically do both of these tests together, and they complement each other a little bit. We're gonna do Renee's test first, or Renee's test. What you do is you need a 256 or a 512. You guys, most of you have 128s, but you have normal hearing, so it should still work with a 128 for you guys. So what you do is you strike the hammer and you place it on the mastoid process, right on their mastoid bone. So right underneath the ear, right there. And you ask them, first of all, can they hear that? Oh, yeah, I can hear that. So then you hold it there till they no longer hear it, and then you bring it up to their ear like this on the outside, and they should be able to, if everything's normal, they should still be able to hear it, because your mechanism of transmitting it through your ear is more sensitive than through your bone. So you should be able to hear it here. This is testing the nerve. Okay, the nerve is working. Then once it goes away, bring it up to the ear. You should still be able to hear it if also the conductive part, the outer ear, is also working. That's a normal response, is that you should hear. Air conduction is better than bone conduction. That's a normal response. But you should be able to have both. You should be able to, you know. However, if you do this, if you put it here on their mastoid process, they hear it. Okay, it's gone. I can't hear that. That's indicative that they probably have more of a conductive deafness than a sensory neural deafness. Does that make sense? You know, if they can hear it when you touch the bone, that means that the nerve is okay and going into the brainstem, but that means that if they can't hear it out here, that means that they're just not getting the vibration of the air to it, okay? This is Weber's test up here. So Weber's test is you take and you put the tuning fork right on the top of your head, right in the middle, and it should sound like you should hear something, but it sounds like it's coming from the top and middle of your head, okay? If you do this and place it on the patient's head and they hear it more on one side than another, then there's an issue there. But you don't know what that issue quite is yet. Most of the time, that's going to be, it should be, a sensorial neural loss, okay? But look at this here. So here's it could be a conductive or a sensory neural loss, so I'll show you. So if you do this and they hear it more on one side, now you got to decide, is it a conduction or a sensory neural loss? So if somebody actually has like wax in their ear and is blocking, like so stick your finger in your ear and do this. So do this, stick your finger in your ear. And notice that it now sounds louder on the side you have your finger stuck in your ear. because you've decreased any noise coming from the environment into that ear, so you're purely picking it up from the. But then you'd have to do René's test to confirm that. You know, you'd have to do René's test to confirm that that's what's causing it. Vice versa, you could, if the inner ear is damaged, you know, and you do this, you do that, they'll hear it more on one side. And then if I go over here, they still won't hear it when I move down to that side that they're not hearing it on. That would indicate the sensory neural, like the cochlea or the nerve is damaged. So anyway, fun to play with. So lesions of cranial nerve number 8 can cause, we've been talking about the auditory parts, so deafness of some type. You can have vertigo or dizziness or a combination, depending on which parts of the nerve. If you're mainly affecting the vestibular nerve part of it, the vestibular part of it, you're going to have more of the vertigo, dizziness, imbalance that you're going to talk about Tuesday. If you infect just mainly the cochlear part, you're going to have loss of hearing. A lot of times it's a combination. You can have both. You can have both being deficits. You guys have heard of an acoustic neuroma? There's a type of tumor that can develop, and it's the most common tumor of what's called the cerebellopontine angle. So the cerebellar and the pons, the cerebellum and the pons, where the cerebellum's sitting off the back of the pons, there's a little spot called the cerebellar-pontine angle just underneath the cerebellum, right where it meets the pons. That's where that nerve comes off. And it just happens to be that that is a common place to get a schwannoma. Schwann cells, the myelin of your vestibulocochlear nerve, cranial nerve number 8, that is a common place to get a tumor, and there's very little room in there, and it can push on that nerve and cause an acoustic neuroma. And depending on how the tumor grows and where it grows, it can cause either more auditory, more vestibular, or a good combination of both of those symptoms of auditory. And they have to go in and resect it. Sometimes they can resect it pretty well without damaging the nerve. Sometimes they damage the nerve. After they do an acoustic neuroma resection, most of these patients now, before they didn't, but now they go to therapy. They go to physical therapy, and you've got to rewire your brain to work with whatever's left of that nerve. And it just takes practice of getting you now, because you'll have a mismatch between, if they actually damage some of the nerve, the hearing we're not worried so much about, and that's something you can't really fix. It's the vestibular part of it. You can't, like, if you have one side of your vestibular system not working as well as the other side, it makes you feel like you're spinning in space. Kind of like double vision. It's kind of the equivalent of double vision, but for your vestibular system. But with double vision, and with vestibular systems actually better at this, you can get it to integrate those signals so that you no longer perceive the difference, and you can reduce your dizziness, and you can get your sense of where you are in the world again. Even if you have less function or a hypofunction on one side and normal function on the other. You got to do special things. You actually got to challenge the system, make yourself worse for a little while to make yourself better. So this is just showing you some of that. This is showing you really big. This would be a really big acoustic neuroma here. And it's in that, this is the cerebellum down here, and this is the pons. And this is the cerebellar-pontine angle is right in there. So this is a massive one. And this one happens to be affecting both. The two cranial nerves that are most commonly affected by this are going to be your number 8, the vestibulocochlear, and the facial nerve. It tends to affect the vestibulocochlear nerve first. It's closer to that angle, and then the facial nerve. This is showing the tumor here. This is how those nerves enter into your skull. You can see the tumor here, and then the tumor comes in here too. And this is, you can see the different parts of the nerve here. They come in together. Here's the cochlear part. This is the vestibular part. Depending on how that tumor grows into that little canal in that opening there, it can push on one part of the nerve more than another. Don't ask me how they get in there and take that out. I'm just, I've never actually watched the surgery or seen how they physically, three-dimensionally, how they get in there and remove that thing, but pretty amazing they do that stuff. Or how they get to the pituitary gland, to your whatever nose. And all right, moving on to things that are a little less important to us. We're going to move through these pretty quickly. Cranial nerve number 9 is the glossopharyngeal nerve. So we are right here. Glossopharyngeal nerve. So we're moving down the side of the medulla here now. We're kind of moving down the side, that outside edge. It's a mixed nerve. However, it is mostly sensory. It provides sensory from the soft palate and the pharynx, so the back of your throat, and taste from the posterior tongue. So all that back of your throat is the sensory part of the back of your throat is the glossopharyngeal nerve. It also provides some visceral sensory information. Okay, so this is some afferent information that's going to help you with parasympathetic regulation, but the carotid sinus and body. Okay, it has a motor component, a very tiny, small motor component to one little muscle called the stylopharyngeus muscle. If you remember that from anatomy, if you guys talked about stylopharyngeus muscle, that is supplied by the glossopharyngeal nerve. It has a parasympathetic component that goes to the parotid salivary gland. Okay, and then it's the afferent limb of the gag reflex. So it's the sensory part when you stick something in the back of your throat. That's the afferent part that provides the afferent component of that. Since it has lots of different functions, it has a few different nuclei associated with it. It has the salvatory nucleus, which is the parasympathetic part of that function going to the parotid gland. We talked about the salvatory nucleus is also used by the facial nerve, right, for lacrimal, nasal, salivary glands. This is the parotid gland. Solitary nucleus is for the taste from the posterior two-thirds of the tongue. Remember, the solitary nucleus was also used by cranial nerve number 7 for the taste from the anterior two-thirds of the tongue. So that's all going to the solitary nucleus. Then we have this little nucleus called the nucleus ambiguus. And it is kind of ambiguous. It's hard to actually see it in a cross-section. It's kind of almost have to imagine where it is. But that's just because it's small, and it just goes to that one little muscle, the stylopharyngeus muscle. That's the nucleus ambiguus. Then what's interesting is that the glossopharyngeal nerve uses the spinal nucleus of cranial nerve number 5 for sensation of the soft palate and pharynx. It's another reason why that spinal nucleus of cranial nerve number 5 is so big. It's being used by the glossopharyngeal nucleus. Its sensory component for the back part of your throat goes to the spinal nucleus of cranial nerve number 5. So it gets a little messy in here. So this is just showing you all those lovely innervations, and you can see most all of this stuff is happening in the medulla. Okay, and a lot of it's up near that pontomedullary junction. So that pontomedullary junction area, you just get lots of cranial nerve nuclei up in there. It's hard to even imagine how the stuff all fits as we keep adding more and more stuff into this area. Like, what? Isn't that? How can you fit anything more in there? So there's the salvatory nucleus right there, up in the upper part of the medulla, going to the parotid gland. There's the solitary nucleus right there, receiving taste from the back part of the tongue. And then here, this is the soft palate and some of the pharynx here. That sensory information is going to that. This is that long spinal nucleus of cranial nerve number 5 that information is going to. Let's see. And here's our carotid sinus right here. And it's going to this little nucleus right here, nucleus ambiguus. I'm sorry, that's not going to nucleus ambiguus. It's going to solitary nucleus. Sorry. It's going to the solitary nucleus. And then this is the motor. This is the motor. Nucleus ambiguus is right here. It goes to that little stylopharyngeus muscle. So again, these are mainly all in the medulla. Lesions, if you have lesion to the glossopharyngeal nerve, you might have loss of gag reflex because you don't feel the back of your throat, so it's numb back there. You might have difficulty swallowing. You need normal sensation, and you need the stylopharyngeus muscle to work to have normal, good, effective swallowing. And you might have decreased salivation because of the parotid gland if you damage those autonomic fibers from the parotid gland. Plus, you'll have decreased taste in the back part of your tongue. So you could add decreased taste to the back part of your tongue. But the front part of your tongue's okay, so you might not notice that very much. But Cranial nerve number 10, vagus nerve. So now we are right there, this guy right there. It looks small there, but it's such a big, long nerve and does so much. It's amazing that it's actually that small there. It is a mixed nerve. It supplies both, it has both sensory and motor to your larynx, pharynx, and visceral. It's a visceral motor, which is really your parasympathetic. So viscera should really be kind of this parasympathetic for control of larynx, pharynx, trachea, heart, gastrointestinal tract, pancreas, gallbladder, liver. So it's supplying a good part of your viscera, driving parasympathetic control of those regions. Okay. So the parasympathetic control over your larynx and pharynx and trachea is primarily that automatic part of swallowing that you're not consciously aware of. That's parasympathetic, peristalsis, and the parasympathetic control of that. You also have some voluntary control over some of that, which is this part of it here, this motor part up here, that is the voluntary motor part of like, I'm choosing to swallow now, you know, versus the automatic peristalsis and those kind of things. So there's a mixture of reflex or parasympathetic, non-voluntary parasympathetic type of control, and then this from the motor aspects. It's also the efferent component of the gag reflex. That's the muscles contracting for the gag reflex. It's a mixed nerve, so it has multiple nuclei associated with it. So the nuclei is a dorsal motor nucleus of cranial nerve number 10, which I don't like the name of that because they call it a motor nucleus, but it's really going to it's primarily driving visceral function, which you don't normally associate with motor. You know, it's not like, it's like the motor system to your visceral structures, but you know, I usually think of that as going to muscles. So it's called the dorsal motor nucleus of cranial nerve number 10, but it's really going to visceral structures. The nucleus ambiguus, which is also used by cranial nerve number 9, the glossopharyngeal, that's the one that's actually going to those more voluntary motor structures of the larynx and pharynx when you want to choose to swallow or stop swallowing, or manipulate something in the back of your throat or whatever. The more voluntary parts of that is driven by the nucleus ambiguus. I would assume that the dorsal motor nucleus of cranial nerve number 10 does influence the motor aspects of the larynx and pharynx that are more involuntary, that are more associated with that so that's probably where they get some of that. All of the visceral afferent information, so to get information about your viscera, gut, liver, gastrointestinal system, to help modulate your parasympathetic output, you have to get information in to know how to adjust. That's coming in through the vagus nerve also. So it's the sensory part. It's the visceral sensory part, not the somatosensory. It's a visceral sensory. That's going to the solitary nucleus. So there's that solitary nucleus. It was used by the cranial nerve number 7 and 9 also for taste, but it's also used by vagus nerve for visceral afferent. So the solitary nucleus is pretty big and pretty prominent because it's getting a lot of getting sensory information about taste, but also visceral information. So this is just showing you, here's the nucleus ambiguus innervating these muscles of the larynx and pharynx. And then we have our sensory structures. We have our solitary nucleus here that is receiving information about the viscera. And then here's your dorsal motor nucleus of vagus. Again, all this stuff is in that medulla. It's packing more stuff into that medullary region. That projects down through the vagus nerve to your visceral structures for visceral efferent motor visceral stuff. If you have a lesion of the cranial nerve number 10, you can have difficulty with speaking and swallowing. You just can't coordinate the back part of your throat. So this is where you have a patient who might have a lesion here. They could be aspirating on stuff, and that would not be good. And they may not even have a gag reflex, so they don't even know they're aspirating because they're not choking. You know, it's like going right down, no problems, drinking those thin liquids, and next thing you know, they end up with pneumonia because they just can't They may even feel the liquid because their glossopharyngeal nerve may be okay, but they can't coordinate any. They don't have the efferent part of the gag reflex, so the fluid just goes right on into their lungs. They might have poor digestion. They notice if you've got, the parasympathetic control to your viscera, to your liver, to your pancreas, to your gut, you'll have just generally poor digestion. They might have constipation, and issues like that. You also might see asymmetric elevation of the palate. If you tell them to go, ah, and you look at the uvula, their palate will only go up on one side. If your cranial nerve number 10 is intact, and you say ah, on both sides, if it's intact on both sides, your soft palate elevates equally, and your uvula, that little thing hanging down the back of your throat, goes up symmetrically, goes up straight up. If you have weakness on one side doesn't go up. When one side does, the side that goes up, the uvula will get pulled towards the side that goes up. Does that make sense? If the damage is, so if you're doing that, if you go ah and you look at their uvula, if the damage is on the side, if it's in the nerve, the vagus nerve, or the nuclei of that nerve in the brainstem, the uvula will deviate to the opposite side of the lesion. So let's do this. If the damage is on my left side, the nerve itself or the cranial nerve nuclei on the left side is damaged, the left side of my soft palate is going to be weak. And so when I go, ah, the right side is going to elevate further, so the uvula is going to deviate away from the lesion if the lesion is at the peripheral nerve or the nuclei level. If the lesion is supranuclear, the lesion is up in the cortex to that area of my primary motor cortex where I'm sending the signal to say ah voluntarily, I go ah. Now the uvula deviates to the same side as the lesion, because this is telling the left side of my left vagus nerve to elevate that palate, because those are crossed. That's a cortical bulbar cross that's tracked. So supranuclear lesion causes the uvula to deviate towards the same side as the lesion. If the lesion's in the nerve or the nucleus in the brainstem, it deviates away. The uvula deviates the same way, but it just depends on where the lesion is, whether it's ipsilateral or contralateral to the lesion. And we have this same arrangement when we get to the tongue, too. Spinal accessory nerve, this is number 11. It's pure motor. It supplies the sternocleidomastoid in the upper trap. The cell bodies for this are actually in C1 to C4. So there's actually a region in your upper cervical spine that has cell bodies, motor cell bodies. The nucleus, per se, it's called the spinal accessory nucleus, and it's actually located C1 to C4. So in your first cervical segments, you have the spinal accessory nucleus, but you also have some of that spinal nucleus of trigeminal nerve number 5. So there's another reason why your cervical spine is a little bit wider and bigger, because there's other stuff in there right now. Because it's a transitionary area. That upper cervical spinal cord and brainstem are transitionary. Cell bodies of C1 to C4. Okay. So here is the spinal accessory nucleus right here, one on each side, and you see it's located. This is the medulla ending here, C1 to C4, and it just goes to the upper trap and SCM. Okay. Don't worry, they have permission to leave. I'm not just sick of me. Of course, I'm out of here. Had enough. So lesions, if you have, if the lesion is in the nerve or the nucleus, it's going to cause ipsilateral weakness on that same side. If it's in the cortex, it actually doesn't cause a lot of weakness, because some of these go to muscles that are proximal and postural, and so some of these are more driven by brainstem, those medial activating pathways, plus they tend to have more bilateral connections. And so if you've got a stroke up here on my left side, I'm not going to have profound weakness of my upper trap and SCM, because there's a lot of bilateral connections coming from my right side, plus I've got the medial cortical, not medial, but medial activating tracts, this vestibulospinal, tectospinal, reticulospinal tracts that also tend to have more bilateral connections, so you don't see as profound a weakness. It's only if you actually damage the nerve that you see a lot of weakness. The nerve or the cell bodies in the cervical spinal cord that you get profound weakness and atrophy of the SCM and upper trap. Does that make sense? You might see that like somebody's like they come into you and they were in a bad motorcycle accident and their head got hit a guardrail and their shoulder hit something else and they got this traction injury and they might have just by chance avulsed or broken that spinal accessory nerve nucleus, and not nucleus but the nerve, and then they might have that profound atrophy. That would be ipsilateral to the lesion. Okay, but if you have lesions above, supranuclear lesions above that, they likely don't see profound weakness in that trap because there's so many bilateral connections there. We're on the last one. Hypoglossal, tongue, motor. This one's easy. One nucleus, hypoglossal nucleus right here. Oh, let's go back here. The hypoglossal, here's a spinal accessory. See how this is your first like cervical vertebrae, and you have the little branches that are coming up. And the spinal accessory is interesting because it actually goes in the foramen magnum. It goes actually up into your skull, and then it comes out a little hole and drops back down. We don't know why, but that's why it can get traction, because if your head gets pushed one way, you can traction that nerve and pull on it. But it goes up, then it drops back down to go back down to your neck muscles. So it's kind of like one of these nerves that got like, wasn't sure which, I'm close to that, I'm not sure, am I a cranial nerve, am I a spinal nerve, I'm kind of both, and it's kind of a, but, so it wants to hang out with cranial nerves and spinal nerves. But here's the hypoglossal. Hypoglossal comes off of this. This is this little, this is called the ventral intermediate sulcus or fissure of the medulla. You have this ventromedian sulcus or fissure. There's a lateral sulcus, which is where a lot of those other cranial nerves come off. This is the intermediate one, but that's where you kind of jump that from the lateral to the ventral intermediate sulcus, and that's where you see a lot of little rootlets that come off to form that hypoglossal nerve. So that's showing you those little rootlets coming off of this, and then it goes to the muscles of the tongue. It has both voluntary and reflex circuits, kind of like the back of our throat. We can choose to swallow, not swallow, make noises, or we can choose to move our tongue, stick it out, make it go left or right, or when we're eating, it works more reflexively. Okay, so we have centers up in our cortex for the voluntary part of it. Then most of the other stuff is brainstem mediated for the reflex activity. So brainstem or nerve, if you damage the nucleus or the nerve, just like with all the other ones we've talked about that have some motor supply, the deficit's going to be on the same side as the lesion. Okay? If it's up in the cortex, it's going to be the opposite side of the lesion. So let's talk about tongue. If I stick my tongue out, I tell somebody to stick it straight out. The muscles on both sides of my tongue push it out equally, and so the tongue stays straight as it goes forward. If I have weakness on my right side of my tongue, those muscles on the right are not going to do their job of pushing out. So only the left side is going to push out. What that's going to do is going to make it deviate to the right. So the tongue's going to be pushed more by the left, and it's going to push it over to the right because it's not being balanced by the muscles on the right. So if I have damage in the hypoglossal nerve on the right or the nucleus in the brainstem, the tongue will deviate towards the lesion if the lesion is in the nerve or the nucleus. If the lesion is up in the cortex, this would be a left-sided lesion going down, crossing over, it's a cortical bulbar tract, to tell my hypoglossal nerve and nucleus to do their job. If that doesn't happen, if it's damage up here, the tongue deviates away from the lesion, contralateral to the lesion if it's a supranuclear lesion. So that's all you just got to if I ask you a question about that, which way, if I tell you that the patient has, a trauma or damage to the hypoglossal nerve on the right, so the nerve is damaged, which way will the tongue deviate? It's going to deviate to the right. It's going to deviate towards the same side the nerve is damaged on because it's not working, it's not helping push out, so the left one is going to push it to the right. If I say patient has a supranuclear or stroke in the left cerebral hemisphere, and I ask them to stick their tongue out, and it's causing facial and tongue weakness, which way is the tongue going to deviate? If it's to the left cerebral hemisphere, it's going to deviate towards the right. If I say it's the right cerebral hemisphere, it's going to deviate towards the left. Okay, so just those are some, and that's the same. It's the same thing that matches up with the uvula, with the soft palate. It's the same arrangement. Is that it'll deviate towards the side of the well, I take that back. It's the same concept, but it's not the same way it deviates. So, because the uvula will deviate towards the stronger side, because where the tongue will deviate towards the weaker side, or the weak side. So just kind of process that and make sure you feel it. I don't want you to get it's not clinically that important. There may be one question on the exam that talks about that, but yeah. I will tell you though, I've walked into lots of patients' rooms, and this is the typical scenario. They come in, they've got a stroke, and I walk in, and they smile, and only one side of their mouth goes up. Hi, how you doing? And they kind of sound like this. Yeah, hey, I'm doing great. Yeah. And then they have got their nice lunch sitting there, and they've got a nice big thing of orange juice, and they've got whatever, and they're sitting there drinking their orange juice. It's coming out one side of their mouth, and I'm like, and like I go, how's that going down? Oh, it's going down fine. I'm like, can you stick your tongue out at me? Can you go and their uvula's not deviating? I'm like, I'm going to take that orange juice from you right now. I'm going to walk out the nurse's station. Hey, has speech therapy seen this patient yet? Or were they just admitted last night? No, they haven't seen them. I don't know that they should be drinking thin liquids right now, because their mouth and their tongue and their back of their throat is not working properly, and they just seem to be having no problem drinking this. And I'm afraid it's going down into their lung. Can we just get a screen of that before they give them back their thin liquids? So that'll happen to you. So but if they say, oh yeah, they've been screened, they did a swallowing eval on them, they're good. Okay, thanks. I just wanted to make sure that was clear, because that kills people. That first day in the hospital after a stroke, somebody gives them thin liquids. Now they got pneumonia. Now they're dead, or you set back their rehab for a month because they've got pneumonia. I mean, that's the stuff that happens. So that's why you want to be able to understand some of this stuff and do a quick screen of that to see what's going on. All you got to know right now with this is all the cranial nerves. Not all of them. This is showing you more sensory on one side, more motor on the other side. So you actually double all these, but just shows you this is that pontomedullary junction region. You see all the different cranial nerves we're kind of cutting across in that region. I think we already talked about this, that for motor control, if you're driving motor control of those cranial nerves that have a motor function, not all of them do, but the ones that do have a motor function, most of them are coming from, if it's voluntary control of cranial nerves, to smile, to stick your tongue out, to swallow voluntarily, those are via the cortical bulbar tracts. And they cross. If they're coming from your cortex, they're crossing over, just like the rest of your body. Okay? Lesions at the nuclei or the lower motor neuron cause ipsilateral weakness, just like the body. If it's up above the supranuclear level, up in the cortex, it's going to cause contralateral weakness. Except for that facial nerve, which the upper part of the face tends to be bilaterally innervated, so you're not going to see much weakness, and also that sternocleidomastoid and upper trap, the spinal accessory, you don't see this obvious deficits in those because of their unique bilateral innervation. But lower part of the face, tongue, back of the throat, that's all very contralateral, types of cortical bulbar tracts coming from the cortex down to those nuclei. Whew, that was a lot. I'm actually surprised we got through that today. Usually that takes like 1.5 sessions, but I knew you guys could handle it right before your exam. So I know this, I said about like letting people review your exams, but this is probably not a great time. People want to spend time reviewing exams. I will have them for other sessions, or if you want to come by my office at any time, but I will bring exams like on Tuesday after class. You could do that, or Wednesday after, between taking brains out or reviewing your exams. So oh, you have Tuesday exam and farm out.